Good afternoon, everyone. Thank you to be here for this integrated symposium organized by the Clean Hospital Project with the nice title of Healthcare Environmental Hygiene, the Last Frontier in IPC. For those who were at the outbreak session this morning, you have seen that environment is often a reservoir leading to outbreak and not easily manageable in terms of cleaning and disinfection. So we have a whole session to speak about this ambitious project and what we have achieved and what are the next steps and the ambition of the project. And to start this session, we are obviously very happy to have the man who has the idea, the vision of this project and wants to give the experience he had with the project around hygiene to even more ambitious projects around environmental hygiene that we do believe it's a really important topic. So I'm very happy to present you Professor Didier Pittier with the vision and the transition between these two big projects. Didier, the floor is yours.
Merci, Pierre. It's difficult for me to say merci, Pierre. Huh? Merci beaucoup. So from clean hands to clean hospital, let's say, think about it. I have no disclosure. So you know my slides. Welcome to the hospital. Infections are waiting for you at the entrance door of the hospital and will complicate your hospital stay. And you know that this is no less than 500,000 patients getting healthcare associated infections worldwide in hospitals every day. Every day, right? The next number you know about it is that 16 million deaths are occurring all over the world every year just because of healthcare associated infection. 16 million deaths. Remember, it's more than AIDS, malaria, tuberculosis together. Far more. Okay? Now, we all know that it's what you call a silent pandemic. I use this silent pandemic wording already 15, if not 20 years ago. And I don't think people understood very well because people didn't know what is a pandemic. But nowadays, everyone knows what is a pandemic, right? So it is a silent pandemic. It's obvious because we don't speak about it so much. But it's still and continues to be a very important problem and a very important killer. So what did we do in the Clean Hands project? Where did we start? What did we do? Where are we today? And where do we go? So where did we start? You know all of that, right? We started with the fact that compliance with hand washing at that time was very, very low, far than less than 40% at the time, and that no hospital, no country, no healthcare system in the world could claim to have solved the problem at the time. I don't want to say that it's solved today, but at the time, this is where we were. So what did we do? We had a solution, and we proposed a system change. So system change was the replacement of washing with soap and water with the use of alcohol-based hand rubbing, right? Now we could demonstrate not only by replacing hand washing with hand rubbing, but by installing a multimodal strategy that we could reduce healthcare-associated infection by 50%, as well as transmission of nosocomial pathogens by 80%. And we used to say, rub hands, it saves money, which is a short way to say, okay, you can succeed, it's cost-effective. I totally agree that the total cost-effectiveness of the strategy using perfect models are still lacking, but we are far away. This multimodal strategy, the so-called Geneva model of hand hygiene promotion, was reproduced with success between 2002 and 2005 in many different places. It was published, it was repeated, and this is the way we started. Then, what did we do? Well, here is what we did. We reviewed the evidence, we installed a multimodal strategy, we developed new guidelines, with implementation tools. We field tested the guideline, the strategy, and the tools. We developed new implementation strategies to allow them to be adapted. We used promotion campaigns. We obtained endorsement. We monitored levels. We installed train-the-trainers program all over the world, and we drove actually excellence. So this is the process. I just show you a few of those instruments, or in case you don't believe me, you will follow that. So the guidelines were developed with the help of the World Health Organization, together with tools. The multimodal strategy, you know about it. It's a 5-mode multimodal strategy. You heard about it in this meeting. I don't want to repeat that. We developed instruments such as the 5 moment for hand hygiene that you have heard of, so you know about it. Those instruments were translated. It's very important, but not only they were translated, but they were adapted by others. That's the ideal framework, when others take what you developed and adapt it to their conditions, to their resources, to the situation. Now you remember Playmobil started to promote hand hygiene in Latin America. Here is what was happening in Germany, here in Japan, and so on and so on. With the concept adapt to adopt. And this is very, very key, because it may apply, and it is actually applying to almost all strategies to reduce healthcare-associated infections in infection control. So remember those 2 tools, the 5 moment, the how to hand rub we developed, that further was tested and validated by WHO, field tested all over the world, and implemented from very modern healthcare settings to settings with very limited resources in a multicultural environment. And you know this, for those who don't know that, I refer to our work and to what we have published before. And also ensuring a universal system change. So it means that what we developed was then adapted to be implemented anywhere in the world. Whether it's implemented today and successful everywhere in every hospital is another story. But at least it has been tested repetitively, and now it works, to the point that the main tool that we offered to the World Health Organization, the solution, the alcohol-based hand rub, became the so-called WHO formulation and was included in the WHO Essential Medicines list. So to this point, it's clear that it is a big help to see such a development. Promotion campaigns we did. No, I showed you several of the things, but promotion campaigns with the help of the World Health Organization, with the coverage that you know from all over the world, covering a very, very, very large proportion of the world population with this campaign. Now, in the what did we do, there are very, very key elements that we are very lucky to get, because we could apply them for many other things, including the Clean Hospitals projects. And these are the 3 monitoring levels: train the trainers and drive excellence. Let me give you these. You know about that. We developed those tools for hand hygiene to monitor practice and ensure sustainability. You have heard about the hand hygiene self-assessment framework, about the surveys that we developed together with WHO, and about the results of those surveys. In 2011, in more than 2,000 hospitals from 69 countries around the world, we tested the tool, and actually Benedetta, who is here in the room, was the first author of a paper that looked at the status of the monitoring of this tool, and in this case only in US hospitals. So if you want, the richest hospitals in the world were tested, and look at this. System change, 100%. Of course, it's easy to buy alcohol-based hand rub when you are a rich hospital and put it at the bedside. But I don't want to discuss everything, but system change is outstanding, but institutional safety climate is not 70% in the US hospital at the time, right? To tell you that these multi-modal programs should really be based on evidence and monitoring, constant monitoring. Now in 2015, together with Claire, Kirkpatrick, and others, we reconducted this survey, and you can see that based on the result of this tool, there was an improvement in blue overall, all over the world, and as well as in every single WHO regions from all over the world, including in the very, very poor, if I want to speak like that, the correct wording is low and middle income country, places and settings. So it means that you can do it if you allow to give the tool, allow to develop, and so on. Where are we today? You probably heard this because it was summarized very nicely in this room early this morning by Marlike the Cracker from our team, who led actually the WHO Global Hand Hygiene Self-Assessment Survey 2019, and you have seen the results. It was presented also this afternoon, at the end of the day, and the paper is in press in the Lancet Infectious Disease, worldwide hand hygiene implementation level. You see here, level for system change, it was in 2019, level for training and education, evaluation and feedback, reminders, and institutional safety climate. I don't want to enter into the detail, and you have it according to the WHO regions. It was shown this morning and repeated by Ermira Tartari in the Semmelweis session this morning. And then we develop a system to achieve excellence in hand hygiene, and for those interested, the Hand Hygiene Excellence Award will be distributed, I guess, in this room today, later around 5. So for those interested, you can access the website and understand what is the Hand Hygiene Excellence Award. In other words, we tell hospitals all around the world, be the next Hand Hygiene Excellence Award, and you come at 5:30 Amphitheater D, and you will see a nice example of these. So this is what we did over the past more than 50 years with the Clean Hands project. Now what's the next step? Could we apply the Clean Hands model to a Clean Hospitals model? Where did we start? What did we do? Where are we today, and where did we go? The same questions. What is Clean Hospitals to start with? Well, it's a coalition of international stakeholders who work explicitly to promote and support healthcare environmental hygiene by research, publication, participation in conferences and events, education and training, specialized working groups. For those interested, you go on the website to understand better and more of what I'm going to tell you. Where did we start? Well, we started by identifying the need, because that's absolutely key. So the healthcare environment remains a major gap in infection prevention and control. It's very, very clear. We need to address silos and fragmentation in the field, which is obvious. There is no one single tool that works, in contrast to what we had for Clean Hands, right? We made a major system change. Here, there are many tools, and we need to understand what are the best. Clean Hospitals official launch was at Interclean Amsterdam in 2018. What did we do? What we did is actually to bring together academia and industry to A, champion the science, the best practices, and evidence-based solutions. B, create a network where project members can exchange and collaborate. C, create a platform from which to bring healthcare environmental hygiene into the spotlight. And you will understand why a little later. Here are the numbers in 2020, what we achieved. Well, 2020 was a busy year, right, because of COVID. Despite that, here is what we did. 9 peer-reviewed publications, 7 other publications. We were present in conferences in person, remotely. We had teleclasses and webinar. We had a teleclass on COVID and fake news. 38,000 attendees during the live session. We had a global Clean Hospital Day organized, and that happened. We wrote a book chapter, and so on and so on. And we had a Clean Hospitals Day teleclass with 21,000 live attendees and almost 80,000 on demand. So it tells you that despite a very complicated year, we actually succeeded. We overreached our objective in 2020. Publications, the slide is not for you to read. These are the publications in 2 years for clean hospitals, which is actually quite remarkable considering the resources that were available. Next question is, where are we today? Now, what we are doing today is continuing our research and academic work. We are expanding our network and connections with industry in particular, and also with academia. We are finding new ways to champion healthcare, environmental hygiene, and patient safety, because that's what you want to do at the end of the story. And where do we go to try to answer to the question? Continued research and publications, academic and white papers in peer-reviewed journals, developed, test, validate, and diffuse the healthcare environmental hygiene self-assessment framework. The same way I showed you a hand hygiene self-assessment framework that we developed, we are developing now the same tool, but a tool that is applicable to healthcare environmental hygiene, a self-assessment framework. We conducted a systematic review of the efficacy of healthcare environmental hygiene interventions on healthcare-associated infections. Alexandra will be presenting the preliminary results of these a little later. We continue to organize the Clean Hospitals Day. It will be on the 20th of October 2021. And we start a new program of the Clean Hospitals Digital Days. So the framework I talked to you about, the hand hygiene framework, we developed the tool that is very, very close, but of course adapted to environmental hygiene. For those interested, you should go to the poster number 193, where the early preliminary results are presented. So it's very fascinating. We conducted an international Sentinel Survey of hospital practices in healthcare environmental hygiene worldwide, and I encourage all of you to access the result of this survey. Regarding the Clean Hospitals Days, many of you came to me asking if it would happen this year. Yes, it will. It is on the 20th of October. It's specifically focused in 2020 on COVID-19, but this year it will be different. We have developed videos. There is this teleclass I talked to you about, webinars, companies' involvement, and social media presence and activities. So the Clean Hospitals Day 2021 will be on 20th of October, like last year. Join us for this and access the website to know more about it. We organize the Clean Hospitals Digital Days. The next would be on the 20th of October, and the following, I guess, on the 7th of December. If I am correct, if I'm not correct, Alexandra will tell me. So Clean Hospitals Days, Digital Days, access the website and you will get more information about it. I can give you a pre-program if you are interested. There will be 3 sessions, one on cleaning and disinfection in healthcare settings. We will review evidence of very important papers that appear in the field with the main authors of those papers. We will revisit the virucidal efficacy of ingredients, as you can see here, and we will have a panel discussion with great colleagues from around the world. Other initiatives include a January 2021 teleclass on COVID and fake news with 2020, with a lot of live attendees, and we will continue to develop those type of activities considering the widespread audience. Website updates on members and partners, press releases, info on COVID, and other timely resources, and approximately 40 short article, press release, and news relevant to Clean Hospitals events and activities in 2020. So from clean hands to clean hospitals, I guess I tried to answer to your questions. Where did we start? What did we do? Where are we today? And where do we go? So if I summarize as a conclusion slide, Clean Hands showed the way to go from 1995. Reviewing the evidence and building intervention strategies was absolutely critical. Monitoring performance, progress, and time trends ensured improvement and sustainability. Clean Hospitals was launched in 2018, so only recently. The model is framed on the Clean Hands model with review of the evidence, developing strategies, monitoring practices, and ensuring sustainability. For more information about joining the projects, the initiatives, or the digital days, you have different website address that I let for you on the screen. I give you a few seconds to take a photo or whatever if you like. And I would like to thank my colleagues for their tremendous effort for all what has been happening this year in 2020 and this 2021, because it was not easy. We were all extremely busy. Despite of that, the project could go on, and I would like to thank the companies who already joined the program, and we will continue to do so in the next future. With this, thank you very much for your attention.
Thanks very much, Didier, for explaining us this journey and the future that we have with this project. And then we'll move to the next speaker with Alexandra Peters from the Geneva team, who is the lead of the research and the scientific research for the Clean Hospital project. So Alexandra will present now the systematic review she has achieved with the Geneva team. It was important for us to start from the base, what are the evidences around the action we could make in this field. For those who haven't performed by themselves a systematic review, it's a huge, huge work. And I was there to see what involvement she had with the Geneva team to present that. And I'm really happy to present you Alexandra. Alexandra, it's up to you.
Hi, thank you so much, Pierre, and thank you for all the work and all the support for this systematic review, and a special thanks to Marie Schmid, who helped me a lot with the literature review. So the systematic review was on the impact of environmental hygiene interventions on healthcare-associated infections and patient colonization. And I have no competing interests to disclose. And what we really set out to do was answer the question, are cleaner hospitals really safer hospitals? And there's a lot of evidence that we can reduce bioburden. There's a lot of evidence that what products work or what procedures work, but we needed to really see what was out there in terms of healthcare-associated infection. And this is a really sort of difficult question to answer because environmental hygiene in healthcare settings is such a broad subject. Hand hygiene, we can limit it to our hands and what they're touching, and healthcare environmental hygiene has a lot of different levels and different elements within it. So broadly, it includes all aspects of the healthcare environment that are not the patient or the healthcare workers themselves and not attached to them. So very often we think about the patient zone, but it also includes any items that are touched during patient care and any shared equipment and common surfaces. So healthcare environmental hygiene is essential for all types of healthcare facilities, whether that's hospitals to long-term care facilities and even in home care environments. And this field is based on both a number of technical and human components, and each of those components have a range of elements. And having good environmental hygiene carries major implications for the well-being of patients, healthcare workers, the community, as well as our larger natural environment. So when we look at the technical components, the biggest of those are surface cleaning and disinfection, water management, laundry, air management, waste management, and sterilization and device reprocessing. And when we look at the list of human components, that includes training, monitoring, cost and value that healthcare institutions invest into their workforce, different elements concerning workflow, as well as career development of environmental service workforce. So we know that contaminated hands can cause an estimated 50 to 70% of healthcare-associated infections, but relatively little is known about the remaining 30 to 50%. And we know that there's some endogenous bacteria on patients that can cause healthcare-associated infection, but we want to know how much is in the healthcare environment. And there's relatively few high-quality studies that link environmental hygiene interventions to a reduction in either patient colonization or healthcare-associated infection. And the reason for this is that environmental hygiene is an often neglected field, and healthcare facilities tend not to invest sufficiently in environmental hygiene. And very often, it's a lot easier to prove the cost effectiveness of a robot for surgery or a new wing of the hospital, but it's much more difficult to make the argument saying that we should pay our environmental service workers better, we should train them more, because when we think about lost surgical revenue or a couple extra days that a patient stays in the hospital due to an infection, it's not always coming out of that same budget. It's not always a direct and easy calculation to make. And so one of the reasons why we did this review is really to show just how important the healthcare environment is. So our study design, the inclusion criteria were effects of healthcare environmental hygiene intervention on either healthcare-associated infection or patient colonization. We only looked at studies with English abstracts, but the studies were eligible when they were in English, French, German, or Spanish. The exclusion criteria, of course, is studies that are in vitro or that don't look at those two primary outcomes. Anything that bundled hand hygiene interventions into the environmental hygiene intervention, and the reason for that is because we know hand hygiene works. We have a lot of data to show just how important hand hygiene is for preventing healthcare-associated infections. So as soon as you include that in a bundle, we can't say for sure what the impact of the environmental hygiene component of that bundle was. We excluded any studies that were conducted during outbreaks, just because outbreaks tend to sort of fade out by themselves and end by themselves. And so again, that would have been too much of a confounding factor to estimate the effect for. And we also included studies that looked at complete structural rebuilds, just because those are interventions that aren't easily implemented. You can't just say, I have Legionella in the water system and now we're going to rip out the whole water system and replace it with a new one. And also because very often in the studies that we were looking at, 6 months to a year after a complete structural rebuild, you get recolonization of the environment. Oops. So our primary outcome was a comparison of the measure of patient colonization, or HAI, compared to baseline. And as a secondary outcome from those studies, we looked at ones that looked at a reduction in environmental bioburden. For our databases, we used PubMed and Web of Science, and we looked at all the papers up until the 30th of December 2019, and then COVID happened. So for our PRISMA flowchart, we started with 952 studies after the duplicates were removed. We excluded 908, which left us with 44 that were assessed for full text, assessed by full text for eligibility, and we excluded 18 of those, and then we had 26 that were included in the systematic review. So the overall results, for our primary outcome, most interventions showed a reduction in colonization or healthcare-associated infection. Now, 88% of the studies showed a decrease in at least one of the organisms tested. This does not mean a significant decrease, but any decrease. 58% of the total studies showed a significant decrease in colonization or HAI for all of the microorganisms tested. 42% were of good quality according to the scoring system, which I'll get to in a little bit, and 81% of interventions were recommended by the authors. We decided to include that in our analysis because studies were often not powered adequately to measure significant reductions, even when methods of environmental hygiene had a lot of promise or had a lot of impact on bioburden. Our secondary outcome were all the studies that analyzed bioburden, and they showed 100% of them showed a reduction in bioburden after the implementation. So we decided to first organize the results by type of intervention, and we came up with 4 main categories of interventions. So one was mechanical, which is basically changing supplies, UV light, using microfiber instead of sponges, anything with air filtration, water filtration, etc. Chemical was mostly changing products. So we used hydrogen peroxide for automated disinfection, self-disinfecting surface coatings, using hypochlorite on surfaces that were previously disinfected with another disinfectant, etc. Human factors, we looked at interventions that changed how environmental service workers worked or performed, and that includes anything with training, monitoring, feedback, certification, etc. And then we had a lot of bundles, and that was a combination of 2 or more types of interventions. And these slides you don't need to read, but it's just to show you sort of what our table looked like. So these are the 8 mechanical interventions, 3 human factors interventions, 7 chemical interventions, and 8 bundled interventions. So from all this, what did we see? So first we saw that there's a whole lot of heterogeneity. The most frequent intervention that we saw was using UVC, which is a mechanical intervention. So 6 individual experiments looked at UVC. 3 looked at training, monitoring, and feedback. 3 looked at gaseous hydrogen peroxide, and 2 looked at liquid hydrogen peroxide. For the rest of the interventions that you can see listed here, there was only 1 study for each of the types of interventions. So what information did we extract from the study? So the title, year, author, study design, intervention, so that's normal. Sample size, we ran into a little bit of an issue, because usually when we think sample size in a clinical study, we think of how many patients. But here, oftentimes, we used proxies. We used how many room cleans, or how many patient days, or so that sort of varied quite a bit. We also had issues with whether or not the studies had a control, because very often there were before and after studies, and there wasn't a control used, or the studies would use what I would call a proxy control. Sort of, they would pick a similar hospital that used a different system than to what they were implementing, but that was sort of similar in size and HAI rates, and then they would see how that worked, but it wasn't really a true control. Looked at microorganisms studied, outcome. Again, the author recommendation and the quality score, both of which I'll get into in the next slides. Then we assigned a grade based on the quality score. Looked at whether there was a reduction in bioburden, and then any additional comments. So concerning author recommendations, authors recommended methods for a number of different reasons, which included elements of the studies beyond a significant reduction in HAI. Sometimes they were recommended because they showed a significant reduction in certain pathogens, but not in others. And sometimes interventions were recommended simply because they had a lot of promise, but the intervention didn't go as planned, because maybe in one case, one of the hospitals wasn't using a wipe that was effective on Clostridium difficile. So it was normal that didn't work. We also looked at the authors also recommended outcomes that were often coupled with a significant decrease in environmental bioburden, even if the decrease in HAI was not significant. So what about study quality? We know that in IPC, we're oftentimes not dealing with the highest level of evidence. So overall, high quality studies were rare. Out of 26 total, only 5 were randomized controlled trials, and 6 had a true control. It was difficult to adapt score for judging quality, because there were frequent lack of controls, or again, this use of proxy controls, or that studies were often not designed with colonization or HAI as a primary outcome. Oftentimes, the primary outcome was bioburden reduction, and then they would just look at that result and compare it to the current rates of HAI in the hospital. So our score assessed 5 elements, which included study design, sample size, whether or not the study had a control, different confounding factors and how they were accounted for, whether there were conflicts of interest or reporting issues, and then each of those things, elements, we gave between 0 and 4 points for a maximum of 20 points, and reduce that to a letter grade, so each letter is equivalent to 4 points. And just to reiterate that this score is not intended for any purpose beyond its use in this review. So the legend of quality scoring is here. And we looked at, the different types of study designs that we had, the sample size. And of course, it's not a perfect scoring system because for an RCT, you don't need the same sample size that you would for a before and after study. So it's not a perfect system, but it did allow us to work with the studies that we got in a much more in-depth way. So here are the studies that scored highly and the grades that were assigned. And then we started looking at microorganisms. So the success of the interventions were partly dependent on the types of microorganisms studied and how successfully specific microorganisms are spread through the environment. So the most commonly studied microorganisms in all of these studies were S. aureus, C. difficile, and VRE. And out of 26 studies, 13 looked at MRSA or S. aureus, 17 looked at the impact of the interventions on C. diff, and 12 looked at the impact of the interventions on VRE. So when we look at only the studies that looked at the 3 most common microorganisms, and we take only the studies that we considered high quality, so with a grade of A or B, and we take out of those studies only studies that had a control, we end up with 5 studies that we went into a little bit more, in more detail. So the 5 studies are the ones that are listed here, and they're mostly quite recent studies with the exception of the one on Wilcox. And the interventions ranged from training to daily cleaning with liquid hydrogen peroxide and feedback, enhanced cleaning practices, disposable wipes, UVC, terminal room disinfection and bleach, and hypochlorite together with training. So when we look at the interventions on C. difficile, we see that there's no 2 interventions that are the same, actually. But we generally didn't have a lot of significant reductions, and we had some total reductions. When we look at S. aureus, we see the same heterogeneity in the interventions, but all of the studies had reductions, although insignificant, in the number of HAIs or colonization. And when we look at the same thing on VRE, we get a much stronger result, actually, which isn't that surprising because we know that VRE is very often in the healthcare environment. But what we know from all of these together is that there's a very high heterogeneity. Each intervention was only tested once per microorganism, so we can't do any sort of meta-analysis or anything with that. And we have a number of limitations. So the field is extremely heterogeneous. There's numbers of confounding factors. Study quality varied widely. Bundled interventions are difficult to assess because it's difficult to identify the specific elements in them. Some studies weren't powered to even show statistically significant reductions. And we excluded some good studies because they included hand hygiene interventions as well. Our review did not include the most recent interventions because of COVID, although most of the interventions that were done during COVID were done in an outbreak situation and would have been excluded. And we only used 2 databases for our literature search. So the main takeaway message is that healthcare environment is very important for patient safety. Unsurprisingly, we need more and better studies that are designed in advance to measure colonization and healthcare-associated infection, but we don't need to wait for those studies to start making healthcare and environmental hygiene a priority. So thank you so much, and thank you to our partners.
Thank you very much, Alexandra, for this tremendous amount of work, because you realize this type of meta-analysis that you cannot do because of the lack precisely of intervention looking at the same intervention, same outcome, turn out to be a systematic review with a lot of work, a lot of review to get this feeling. But it tells you also a lot about the field of environmental hygiene, which we all know is something that certainly deserved a lot better research and science than what has been applied yet to this research and science. But that's a fascinating part. It means that we have a lot of work to do. Thank you. We'll come back to questions at the end. And now that's my pleasure to introduce Pierre. Pierre Parneg, who is the hospital epidemiologist and also environmental hygiene expert and infection control expert at the University Hospital in Bordeaux. Pierre today is addressing the issue implications, analysis, and future perspectives of environmental hygiene interventions, because the idea is really to look at what is active in the field. Thank you very much, Pierre.
Thanks, Didier. Waiting for the first slide to come. She doesn't.
Just press one. Just press one. Well, we'll not lose time. We will open to questions of the two first presentations while the system will allow us to get the slides. So open to question. Benedetta.
Thank you. Congratulations for this session. That is very interesting. I wanted to ask a question to Alessandra with a premise. When we developed the core components for IPC programs, cleaning is included within core component 8, which is about the built environment. And at the time, which was, we did a systematic review until end of 2015, there was really insufficient evidence for this core component, to the point that the experts decided to go for a good practice statement, which means that you make a recommendation because it's obvious that the intervention should work, but there is no evidence that is sufficiently good to develop a proper recommendation. So the question to Alexandra is, according to your review, do you think that now, 5 years later, there is more ground, in your opinion, for developing a proper recommendation on cleaning?
I think absolutely. When we look at the 5 studies that looked at the 3 most common microorganisms, so all of them except for 1 was after 2015. And so it's true that in 2015 there wasn't any evidence for it. And at least, I mean, with a microorganism like VRE, I think that there's overwhelming evidence that you can get significant reductions through interventions. But looking at the whole sort of body of literature that we looked at, and looking at how, I mean, I'm actually surprised that we got as many significant reductions as we did, considering that many of these studies weren't even setting out to find that. So I feel like we're probably underestimating still how important the healthcare environment is, even when the results of the studies, you know, show that we have reductions, but they're not significant. So I would still say just the fact that 88% of the studies showed some reduction in at least one of the microorganisms, when they weren't designed necessarily to show that, is extremely encouraging.
Yes, please.
Well, first of all, thank you very much for the impressive systematic review. My name is Mark from the Netherlands. And I completely agree with the last sentence on your slide. We do not need to wait for those studies to start making healthcare, environmental hygiene a priority. So my question is basically, how would you suggest to take action in the meantime?
I would suggest working through organizations like Clean Hospitals, as well as continuing in your own institutions to work on these kinds of questions, making sure that the IPC programs work very closely with the people in charge of environmental services, and really sort of changing norms and culture within hospitals themselves. So I think we don't need to pick one thing. You know, we can drive the academic side forward. We can work on how we treat the people we hire. We can work on, these types of public-private partnerships, because what's important is that we get out of this over-segmentation of this field, and that we stop thinking of environmental service workers as housekeeping, and we start realizing how important and crucial for patient safety all of these elements are, and then I think we can drive the field forward on a number of fronts. Thank you.
Thank you. In the meantime, the slides are on the screen. So Pierre, thank you very much.
Thank you, Didier. So, no disclosure. As Alexandra said, and with the work done before, there's a link, obvious link, between environmental contamination and infectious risk. If the room is contaminated by a patient before you, if there is a patient at risk before you, you have a higher risk of acquiring the bacteria. Obviously, in regard to, and the study shown that too, biocleaning is frequently imperfect, but it's not possible to be perfect in everywhere, especially in biocleaning. And biocleaning is not assessed, the quality is not assessed everywhere. In France, we do not assess a lot the quality of biocleaning. And the questions are numerous and not easy to answer to, which level of quality I accept, for which microorganism, as Alexandra displays, for which patient, situation of care. So the spectrum of question is very wide and not easy to answer, but we need to have consensus statements around that. So the challenge is how we assess it and how to fix it when the problems are there. So as Alexandra displayed us, there's a wide variety of effective solutions to reduce the risk. So not only one solution, like end-rub product to end disinfection, but a wide variety of things with small amounts of conclusive studies for each one. A lot of pitfalls to design the studies, as Didier said, and it's not easy to build this kind of studies. And at the end, even with very good studies, not easy to quantify the link between environmental contamination and infection. We have really that during the COVID crisis. I do like this Japanese model for modeling from which contamination is coming. It's just a mathematical model, but based on really good data. So it's made in condition of caring, so with all the kind of transmission route that has been assessed and modelized in two situations. The first one, healthcare worker have contact 1 minute 20 times a day with the patients, and the other time, a little bit less frequent, 6 minutes, less frequent, 10 times, but much longer, 6 minutes. And in blue, you have the part environment. So it changed rather dramatically according to the viral load of the patient, so it's quite different. It changed according to the time you have spent with the patient. So telling that will one day tell you exactly what is the role of environmental contamination in transmission of that or that microorganism is not true. But there's a role played by this strategy. So you should tell me, as the end came first in contact with the surfaces before the patients, and hygiene could solve everything. It's not my opinion. You know in practice that and hygiene is not perfect and will not be perfect. So it's both important to control the transmissions, it's the first step with hygiene, but also to control the reservoir and to make it as scarce as possible with cleaning and disinfection. At the time, environmental hygiene is not an option, or is no more an option. When you have some doubt, and it's the karma, the daily life for the ICPs that you are in your hospital. When you have a doubt, you go back to the roots, the core components for infection control. And in the last version of this document, it was not a recommendation by WHO. It was a general principles, some kind of prerequisite for making care activities. You need to work in a clean and hygienic environment. It's a basic. In France, we have designed in 2018 a job and skill repository for all the specialists in infection control. And we have worked with specialists of this field, and we have assessed 9 situations of global activities for ICPs that are the most representatives of what they are doing in France. And among its 9 situations that we call act knowledges, you should know how to act and how to mobilize your knowledges in the real life. 2 are linked with environmental hygiene. I will focus only on the first one, develop and conduct a prevention plan for infectious risk related to environment, air, water, surfaces. It's the daily job of an ICP in France and elsewhere, I'm certain too. What are the goals for that? I just will show you the goal and now how to do it with the whole presentations. Expected results that are important to display for a CEO, patients or residents receiving care in a secure environment with regard to the risk of infection. The structure can act on the basis of an efficient plan, adapted to its activity, obviously. Decision maker, the CEO and the other, have the elements to monitor the environment and comply with regulations. According to the country, you have some regulation. In France, it's strong for water and air, less for surfaces. The professional should have understood the risk associated with environment, and non-compliant results are checked and processed. Often, they are checked but not processed when there are non-compliant results. So, to receive care in a secure environment, it's not that easy. And the idea of security is quite wide. I like this paper from our Irish-American colleague, Claire Rock, evaluating what the perception of patients, healthcare workers, of the UVC use. Not the real impact, but the perception. And if you like, to the first part is the patient survey. If you ask the patient if UVC light helps protect me from an infection, the world patients feel safer with UVC. They have no idea about the real efficacy at the end, but they feel safer. And the healthcare professionals have more balanced vision, but they are happy to use the technology that could reduce and protect the patient too. So the patient vision, globally the patient experience, is something really important in hospital, and you should have that also in mind when you design your strategy to infection control. So, how to make a professional aware of infectious risk linked with an environment? It's a daily job, it's not easy. I just pinpoint one study, for the New York team of Elena Martin. For those who will attend the first digital days, she will present the World Project, and on also the day that will be the Clean Hospital Day, so October 20, keep it in mind. It's the result of the quality of the environment, disinfection and cleaning assessed with ATP method. So you can see that the first bar is the pre-education results, the second bar, the post-education results, and the third, the result 1 year later. So you can see for the bed rail, a very poor level of compliance, under 10%. After education, you're nearly at 50%, and even 1 year after, it's also better. There's also a slight decrease in C. diff infection in this study. What is interesting in these studies, they have based the project on behavioral science, and for us it's really important. Understanding the barriers for which healthcare professionals in charge of cleaning are not doing perfectly the job. So it was the first step of a previous study that they use in the randomized trial that they have performed recently. And as you see that, there's a lot of reason for which a healthcare professional is not performing perfectly his job. Sometimes you're well aware of that, but sometimes not. Maybe they're reluctant to disturb the patients. It's a thing you have to keep in mind. Tell us, no, you should tell to the patient to remove things that were on the table to be efficient in your job. So, as everywhere, and it's also a project of Clean Hospitals, is to use behavioral science. We have connection with the London Centre of Behavioral Science. We haven't started because it was during the COVID crisis, but we hope to start that in place to propose this kind of tools for hospitals in the future. So how to check non-compliant results and how to process them is interesting. It's not easy. What are a strategy? Do you use routine universal intervention or targeted when we have some problem or some microorganism? What is the level acceptable? It's not easy. For aspergillosis in the air in France, it's 0. When you have 1, you have a problem. But what is the extent of the problem? Do we need to close the operating room? So it's not easy to define this kind of standards, but we need to have some kind of consensus around that. And what is cost effective is it's not easy, and work ahead of us. I think one important aspect is in our field not to confuse revolution and progress. It's very rare to have a revolution in the field of infection control, and that some innovation will make a dramatic decrease of the infection rate. It's not possible, and the literature is showing us that it's really difficult to gain. So we need to accept some progress, some new technology that will not decrease infection, but that could help us in making progress in the hard challenge to control environmental infections. For that, we need standards. At the end, if a product is not able to show you that it decreases infections, it must show you that it decreases on surfaces the contamination. That's what it has been designed for. And for that, we need standard in order to compare the quality and the performances. And you, as infection control practitioners, you're in charge to decide whether or not this progress could be useful in your hospital. So working on the standards and promote new standards when there's a lack is also a goal of our project. And we have worked already around that for antimicrobial surfaces. The surveys we made of the UNITIPS groups at the time among scientific society, and it was a British answer about what will be the best things in the future. We all expect that, and industrials also are working on that, but okay, there's a dream and there's the reality, but the purpose is that the dream reach the reality or the opposite maybe. So the fight is not very simple. You have the patients, you have the SCPs. The infectious risk is more for the patients, but during COVID crisis, we have seen that healthcare professionals are also targeted by the risk. You have the burden of care and the musculoskeletal disorders, normally only for the professionals, I hope so. The chemicals hazard are balanced. Professionals are more exposed, but the patient could be exposed too. We have the challenge of environmental hazard that you should address now. It's not possible not to have this in the equation. The patient has his vision, we said. You have representation, expectation, experience. It's not scientific, but it's mandatory to take it in account. On the other hand, you have all your healthcare professionals with the knowledge, the attitude, and the practice, and you should address also the difficulties you could have around that. So, obviously, better science means better efficacy of a strategy. It's obvious. We need implementation science. It's really an ambitious of this project. I hope we could succeed to work in a soon future with our colleague in London. Awareness is still important. You could say with COVID crisis, awareness is there. It has been there, but it could go back very fast to the normal of the years before. So the digital days is here. The self-assessment framework is also on the way. For us, it's very important. The Clean Hospitals Days is also important to disseminate. After the first Clean Hospital Days, we have some value of the cleaners in the world, and for us, it's important to value this profession. It has been valued during the COVID crisis, but we still need to value this professional. Obviously, it's a DDA project, so we need to be worldwide. It's important. Everyone should have access to environmental hygiene. And obviously, every positive mind is very welcome in this project. So as tomorrow, most of you will be ICPs in the space, I found some paper. There are very rare literature on this important topic. I like this American one. And as you can see, the problem in the space are nearly the same as on Earth. And maybe environmental problems are even more important that as the space is limited, you have a lot of high-touch surfaces, air and water are difficult to control, waste management is a trouble, and so on and so on. So when you'll be the next ICPs on the space shuttle, you could, like Thomas Pesquet, see Geneva like that. So I must recognize, as only a Frenchman from the West Coast, not a Geneva guy, that I've spent a lot of time searching the famous fontaine, and at the end, I feel I got it. Thank you very much.
Thank you very much, Pierre. So it was our intention to keep a larger place for questions, and that's why we restricted ourselves into the length of our presentation so that you could ask all questions you wanted to ask. So the floor is open to question. Don't hesitate to come to us and any question. Yes.
Hello, thank you for the brilliant presentations. I would like to know if you've managed to have hospitals on board of the Clean Hospitals initiative.
Well, yes, we initially opened the initiatives to hospitals, but the problem is that immediately we would have so many hospitals who want something for their own and a response for their own problem, and to ask, well, by the way, I'm doing, here is our protocol. So what we did, Alexandra will explain to you, we are actually working on what we call a transposable model. So there are some model hospitals. There are many others. Alexandra will give you details about those. And we thought that to start with, to have like a few model hospitals that we consider as models for different reasons would help us to draw a first model that could then apply. Now, behind the framework that Alexandra showed you, actually in the poster she presented, well, you can speak about it a little bit. There is all these sort of regards towards standards to develop. It's not, we are not talking about standards that are here, present. If yes, the talk of Pierre would be very easy. He'd say, oh, here are the standards, that's it. And that's exactly what Pierre told you. I mean, we need to, in every hospital, there are standards. In my hospital, we had to build up standards for surfaces, for water, for operating theater. We have our own standards. Number of CFUs per square meters, per cubic meter, how frequently should you screen the environment or not, and so on and so on. But our standards are standards for University of Geneva. Are they valid? Have been validated? Well, they are validated by our experience for the past 25 years, but whether they are the correct one, the only field where we have real standards in hospital environmental hygiene is the field of the quality of the water for hemodialysis. Well, for hospitals with no hemodialysis, that's not very useful, right? And even the standards are not the same in France than they are in Switzerland. So I think that this is where we are in this field. So I will ask Alexandra to answer to you.
Sure. So when we were beginning the development of the self-assessment framework, a big part of that was gathering in-depth data from hospitals that we considered models, and then also gathering ethnographic data from hospitals that were very different from our own. And so we had the opportunity to, through the hand hygiene train the trainers programs, to travel quite a bit, and then we're invited to go look at the environmental hygiene in a number of different hospitals around the world and really sort of see what the elements in those hospitals are that are working for them. So it's not just to see problems, but I mean, one thing that really impressed me once was actually when Emine invited us to Turkey, and I got to visit the hospital in Urla. We saw that there was this incredible team building between the environmental service workers and the head hospital administrators. Everybody knew each other, everybody knew each other's families, and everybody really felt like they were part of a team. And when they were doing educational materials or when they were working on different protocols, you saw this type of cohesion that was really, really special and really marked, and not something that I could have found out from a survey or from had I not been there. So I think it's really about when we were working on this tool, it's really about finding all those little gems, and as well as the issues that you can't really, anticipate without being in a certain context, taking as many of those as possible, and then making a survey that's at the time, at once as specific as possible while being as inclusive as possible, so that healthcare institutions can really, look at it, assess themselves, and then look at how they change over time. Because the biggest goal is really to assess yourself against yourself. And that's also important to mention, that this tool isn't to create a standard or a benchmark or anything like that. It's really to help hospitals move forward in different areas around the multimodal strategy of the WHO. So I think in a first time period, that's the most concrete way that we can include hospitals actively in what we're doing. And yeah, so thank you.
There was a question here first.
Thank you. That was a fantastic session. Thank you for that. Listening to the data that you've presented, it brings to mind some of the challenges that the water, sanitation, and hygiene community have faced. There have been lots of trials which don't really show that toilets are particularly effective, and yet we all know that they work. So following on from your systematic review, do you think there is an argument for bringing a group together to think about what the ideal components of standardized trials of environmental hygiene are going forward, and really thinking in granular detail about fidelity of implementation as well as efficacy, and what the statistical modeling techniques should be to assess that, and even thinking about standardized approaches to quantitative microbiology?
I think that would be brilliant. Yeah, I mean, absolutely. And then looking at different types of interventions and how measuring those or designing those studies should look differently from each other. No, I think there's so much work to be done. Thank you.
Yeah, I think what is very exciting, thank you for the question and thank you for the suggestions. I think what is fascinating in this model, and it goes back to what Pierre told us earlier, I love what you say, don't confuse revolution and progress. In Clean Hands, we had a system change. We had the capacity of a system change, which is stop using soap and water, use alcohol-based hand rub. Now, everyone thought it was the solution. Well, it's not the case. In hospitals where they, from one day to another, had the alcohol at the bedside, it didn't change anything. You had to install a multimodal intervention for it to work. Whether the multimodal was always multimodal with the 5 modes and so on and so on, it's another story. It was adapted, it was transformed. So the alcohol-based hand rub was the tool for change. It helped a lot, because without it, it would never have been possible to transform behavior. In the Clean Hospitals project, we also need to transform the behavior. We need to transform the behavior of the CEO, who assumed that the cleaner in the hospital, the less you pay him, the best for you. And even some assume, why don't we ask outside the system to come, and we don't even have the salary of those people. And you have these very sophisticated systems that are there, and you don't know exactly what to do. But the recent story, and I'm unpleased that Benedetta left, because when WHO reviewed the literature and when Alexandra reviewed the literature. Since then, there have been multimodal strategy that with beautiful papers that really tells you, and we knew about that in infection control, because if you want to prevent VAP, if you want to prevent catheter-related infections, if you want to promote hand hygiene, if you want to promote urinary tract infection prevention, you need to use a multimodal strategy. So it's exactly the same for the environment. It's a little more complex, because not everything that we are using is useful, and we are not using some things that are extremely useful. So that's the complexity of the project. And the good thing is that we don't need to have the results of science to start yesterday, to start tomorrow. There was a question earlier. But we really need to fine-tune what we are doing to be more convincing. Because the day you go to a Ministry of Health, and Emine, what used to be Ministry of Health, and say, listen, we need this, and this to clean the environment, the Ministry of Health will say, okay, what is based for? Whether it's based on pure science, or whether it's based to visit 1,000 hospitals in the world that try to develop the best model, and if possible, a cost-effective model, is what we need to bring as answers. And I'm convinced, remember, hospital environmental hygiene used to be very, very, very important in Germany, not important at all in the US, 30 years ago. Then, nowadays, we are coming back, and COVID helped us, because COVID and environment was a real issue, in fact. Poorly documented, but a real issue, I can tell you. Papers are coming now. So it means that we are really, it's a good opportunity to see, okay, now we know we really have to invest in this field. And of course, it's not easy, because we don't have the tool to transform everything, but we have at least the willingness to do it, and I'm certain that there are many, many, many places asking for simplified, optimal tools to change behavior and, of course, to improve patient safety. That was a long digression. There were a few, you were first, and then you will be next. Go ahead.
Thank you very much for putting the spotlight on cleaning. Really, thank you. My question is with the multimodal strategy and the build it part. Appropriate staffing is also important. Is there any work ongoing as well to try to define what is an appropriate staffing level, or at least have maybe a survey now on what's the situation now on staffing?
The appropriate number of staffing for cleaning and disinfection is not now at the time. We have searched what is used. What is used worldwide at the time is calculation made in hotels and things like that. And it's from that we have adapted in the world the number, but we have zero idea of what is exactly required in hospitals. It was quite strange to discover that all the grids are coming from the hotels and this kind of industry, and have been adapted by some in their hospitals, in their country, and things like that. So we have strategy around that, and it's important. In France, we have changed. We were building hospitals vertically, very high, and now it's smaller hospital, but with very large surfaces. And when they moved from one to another, it was the same number of staff, but the surfaces was tripled. It was nearly impossible to do the job. It was impossible to do the job. So it's also something we couldn't find scientific evidence to say that is the number, but it's also something we should progress to have standards more adapted to what is healthcare.
Yeah, and it comes back to the transposable model we want to develop based on evidence, provided we have the evidence, and based on experience by visiting hospitals and taking the best of those hospitals to give it to others. That's as simple as it is. And of course, adapt to the resource conditions. And yes.
Thank you very much for the session. It's absolutely brilliant, and I think it's a good opportunity to come together as a community on this. I'm Georgia Gon from the London School of Hygiene and Tropical Medicine. We've been working now for several years on environmental hygiene in low resource settings, And I think it's probably worth highlighting kind of the different stage of some countries where, I mean, we've done formative assessments in over 100 facilities across Africa and Southeast Asia, and there is literally zero formal training of cleaners and a genuine knowledge gap. And I am entirely pro, like, multimodal strategies, but I also think that for this specific issue in low resort settings, we're almost starting from almost like a step back, where even knowledge is something that we need to focus on and get almost going back to the basics. And so, yeah, I think it would be great actually to understand from you, also from your review, whether you found evidence of effective interventions in these type of contexts, and how you think that can sort of improve that strategy for those contexts in the future. Thank you. Over.
Yeah, so in the systematic review, we have found strategies in what we were calling human factors, so training and education, feedback, etc., that have had really good results. What was also interesting was a different project that we did, which was the one that Professor Pité just showed on one slide. That was the Sentinel Survey, where we got data from 35 different countries. And it's not just a low resource problem. Huh? There's a lot of countries, even in high resource environments, a lot of healthcare facilities that don't have training for their cleaners, that don't have management on site. The cleaners don't speak the same language as the nursing staff. There's no communication on the work floor. There's no clear assignment of who does what. So although, and actually, we then divided the answers that the data that we gathered by higher income and lower income groups. And some of the differences were, of course, more marked in lower resource settings, but a lot of them are a global problem. And now everything that has to do with training and education is one of the main 5 components of the multimodal strategy. And so I don't think that we could, if you only focus on training and if you have no tools, it won't work either. So I think it's really, it needs to be a bottom-up approach. It needs to be a grassroots approach where each facility decides for themselves how to take ownership of this project, and that we're able to have the data and give them the tools in order to implement those changes effectively and sustainably. Thank you.
Thank you for your comments and answer. We do not hesitate to collaborate with you. I can tell you that, yes, to fuel what Alexandra told you, in Geneva in 1995, 1996, we had a fusion of the hospital, and the Boston Consulting Group came and they say, you have a much too large number of people to clean the floor, and okay, they reduced it by almost half. And that was terrible, but we had to reconstruct the way you clean, and this experience will be used, and is used actually within the transposable model. In the UK, remember, there was the phase where CDIF was terribly active, and where we could demonstrate that the cleaning of the environment was probably responsible for the epidemic and so on. So we have element to help to say, don't play with that. Don't play with that. You need to take it seriously. What you need to do is never exaggerate and try to come with good information to help doing those changes. But it's clear that you need to recognize those people making this job, you need to recognize their salary, you need to train them, educate them, and within the education process, recognition is absolutely key. Until a few years ago in Switzerland, there was no training for those people. I mean, they were hired, and then somebody would give them tools and they would do it. Like probably in many other places around the world. Now it has changed a lot over the past years. So let's try to benefit from what has been done in different places and make sure it's something we can disseminate widely. Yes?
Bartosz Danget, Sangi Suisse. Thank you so much for this amazing 3 presentation. It was really a pleasure to listen to you. I have a very specific question concerning to what you just said, Didier. Is there a plan to determine how many people, depending of course on the number of the beds, should hospital possess to ensure a perfect cleaning, let's say? Thank you.
Yeah, well, it comes back a little bit to the questions that was asked to Pierre a little earlier. In fact, what we are currently doing is to compare what is used where and for what. Because of course, there are surfaces, like in our hospitals, that you clean differently than surfaces in the operating theater. You know, it used to be that my office was cleaned every day, you know, and the operating theater was cleaned every day too. So it doesn't make sense. I don't need my office to be cleaned every day. I prefer the resource for cleaning of my office to be used in the operating theater. And the new technology also helped to probably do this translation and so on. So we are looking at what is the existing situations, because if you come to the CEO and say, listen, we need twice more people to clean, the CEO will say, okay, thank you, you are a nice boy, but I can't. And I'm not sure it's that simple. I think that, and even the recognition, during COVID, what happened, in certain area of the hospital, we needed a tremendous investment in environmental hygiene. So what did we do? Naturally, we took some people and we asked them to go to clean, for example, in the ICU or whatever, people who never went there before. But because the motivation to do a good job and to apply what was needed to save lives was good, these people did tremendously well. So this, of course, it's a specific situation, but I think that by building up a nice education recognition strategy, that's why I like the prior question, is these people need to be first recognized. And once they would be recognized appropriately, and this is the case in several hospitals, they are always ready to do a better job and to do it with the best that they can do and provide them good tools. And in our thinking and in our models, there are also a lot of good tools to help them to practice their job in better conditions. Remember that when you have to do this 100 times a day, and it's difficult for your back. Now we have a lot of much better tools, including in low and middle income countries, that are very simple to improve this situation. So ergonomics of work is also something we are looking for.
Maybe in addition, we are realistic. We will always face lack of resources from time to time. But for us, what is important is that we feel that it's our duty to define the priorities when there is a lack of resources, not to let the cleaners select something according to what is feeling at the time. We know that in front of infection control, the professionals are not rational at all. We have experienced that for infection control and hygiene. When asking people what is clean and what is dirty, for some hospital professionals, a baby is clean, an elderly person is dirty. So you have representation like that. So someone will see something on the floor, say it's dirty, but another thing. So we need to be realistic, and in situation of shortage of resources, we need to say the priorities are that. You have the time to do that, do that. We will see when we have more resources and task force what we could do in addition, but today we don't let you alone deciding that you will do 1 room on 3. We tell you what are the priorities, and I think it's also an important part of the reflection of the project.
A question over there. Yes, go ahead.
Yes, my name is Kay. I work with a mobile infection control team in France. Maybe it's more a comment than a question. During the COVID pandemic, we actually tried to encourage healthcare teams to incorporate cleaners into their discussions, because what happened was that the nurses, directors and all, they would know what they're doing, but the cleaners would not know what they're doing, and they would get very confused with the management of the COVID situation. And that actually came from our experience with nursing homes before the COVID pandemic, where we would see when there is no communication between the cleaning staff and the health staff, a lot of things can go wrong. They may not use the right product, they may not actually be doing whatever we're saying that they should be doing about hand hygiene and safety equipment, and we actually need this kind of communication. So I think even before we talk about increasing staff and before we talk about training them, just encouraging the communication and including them into our IPC training and including them into our conversation is a big step forward. Thank you. Oh, and I just want to make another comment too about the movie last night, which was really amazing, the Romanian movie about the collective and what happened there. Thank you for sharing that.
Just a comment in addition, it reminds me a situation during the COVID crisis in the nursing homes. There was shortage of resources for cleaning, and they have decided to double the frequency of cleaning of the common surfaces, the restaurants, and all the things like that. So they stopped cleaning the rooms of the residents and the patients. But at the same time, the patients and the residents were locked in their room. They were no more going outside. So from time to time, you have this kind of situation, and you should help. And it's the role of the IC team and the one of my colleagues. You should help the nursing homes or the settings to realize that they are not doing the right thing in this situation.
But we are coming to the end of the session. If there is no more burning questions, or if there are more questions, we could stay in front and you can come to us. It was fascinating. I see that the audience is a large audience for this afternoon. It's time now for tea break, or coffee break for those who prefer coffees. Right, getting out of this door, you will be immediately on the spot. Take this opportunity for sharing with each other, and have a nice rest of the afternoon, and see you either during the end of the day or tomorrow for the last morning, and with the last surprises of the day, including a cheese party that you will have at the end instead of getting some meat. There will be a little Swiss cheese party right after the closing ceremony. So see you all, and thank you very much.